Hi everyone. We are at the third World Congress of Cardiometabolic Diseases. We are at Leela, Mumbai, and we are fortunate to have with us Dr. Amrish Agarwal, sir. He is a senior cardiologist from Fujira Hospital, UAE. So we thank sir as he has come all the way from UAE to attend this conference. So we begin this discussion by asking sir what we actually understand by cardiomyopathy, and the sir has spoken about amyloidosis in cardiomyopathy. So I'll begin by asking sir that what do we really understand by cardiomyopathy, especially for the normal public?
Thank you very much. So, as we know, the cardiomyopathy is a disease which affects the muscle of the heart. And one of the reason is that the function of the heart becomes dysfunctional, and obviously there's an impact of that one. So, normally we were not recognizing this particular type of cardiomyopathy for a long time, but now we know that nearly 15% of population with the heart failure are having an entity which is called as ATTR cardiomyopathy. And there is a big component of patient with aortic valve disease, and in fact 15% aortic valve disease patients, at least in the elderly, can have this entity of ATTR cardiomyopathy. So what is an ATTR cardiomyopathy? It's an unfortunate disease because heart is not the primary organ causing the disease, but heart is affected by the disease. In the liver, so inside the liver, a protein is synthesized which is called a transthyretin. This protein, when it comes out of the liver, has got four components, and this normally, in normal everybody, these four components, they stay together and they circulate as a single ball. But in ATTR cardiomyopathy, the four components, they become separate from each other, become into four pieces, and the four pieces go a rearrangement and become long fibrils. And these long fibrils are deposited inside many tissues of the body, in which the heart is one of the tissues, but they get deposited in the kidneys also, they get deposited in the nervous tissue also. So when they deposit in the heart, they obviously interfere with the function of the heart and give rise to a disease in which the heart is thick and heart is stiff, and the heart is not able to relax properly and contract properly, thereby giving rise to a condition which is called as ATTR cardiomyopathy. So ATTR cardiomyopathy, like I said, is a under-recognized, under-diagnosed condition, but it seems that a big chunk of population is having it. Now, why the interest in the disease has come up recently? Because we have now a molecule which is called as Tafamidis, and this molecule is nothing but a stabilizer of this four-component protein. So when you give this drug, the drug is absorbed very rapidly. Within 2 hours, the drug will enter the body and will target each and every circulating transthyretin protein in the body and stabilize it. So the way it stabilizes, that the ball cannot dissociate into four component and does not get damaged by rearranging into longitudinal fibrils and thereby arresting the process. So once the deposition and the production of the fibrils is stopped, the body's own mechanism will clear off what has been deposited from before and thereby reversing the cycle. So this drug is now revolutionized the treatment of ATTR cardiomyopathy, and the people tend to live more longer. So if I will tell you, there is a trial which was done which included 441 patients. It's a pivotal trial because it's the first trial which showed that we can actually reverse the consequences of ATTR cardiomyopathy by giving this molecule. And by giving this molecule, 1/3, so out of every 3 patients, 1 patient will live longer. Out of 3 patients, 1 patient will have less amount of heart failure. And not only that, their quality of life will improve. And how do you assess by quality of life? By doing a test which is called the 6-minute walk test. You make the person walk for 6 minutes, and this goes up from 300 meters to 50 meters by 75 meters. So you are talking about a big improvement in the quality of life in this situation. So this is sums up the ATTR cardiomyopathy.
Exactly, sir. What we could understand is that people are really underdiagnosed in this condition. It is prevalent in about 15% of the cardiac cases, but still we are unable to establish the correct diagnosis. So I would ask, sir, like what are the diagnostic modalities available through which we can diagnose this condition and start the treatment early?
So like I said that this condition is known for quite many years, but we were not able to diagnose it properly because the tools for diagnosis were not very clear. Before they involved cardiac biopsy, and obviously you cannot take every patient and take to the cath lab and take a chunk of the tissue and send for pathology. I mean, nobody will agree so easily for it. But fortunately now we have some disease, some components of diagnosis, and the whole component diagnosis is two things. First of all, to exclude for monoclonal bone marrow condition in which the monoclonal cells are synthesized in the bone marrow. You do this by doing a urine and a serum electrophoresis. If that is normal, then you go to the second level of test, which is a very simple test, which is called the bone scan. So it is a bone scan, but the bone scan, because this particular ATTR cardiomyopathy has got a unique property, it is able to take the compound we use for bone scanning in a very rapid way and takes it inside the heart. So very simple logic is that if you give this bone scanning compound to the persons with ATTR cardiomyopathy, the heart will light up like a bone. So if the intensity and density of the accumulation of the compound in the heart is equal to that of a bone, when we talk about bone, we're not talking about the skeletal bones, we are talking about the rib cage, then the person is said to have a positive test, and such a positive is 99% of cases will indicate ATTR cardiomyopathy. Bone scan in India is available in every city, and most of the major city have it, can be done in 1 hour time. In our hospital, we are fortunate enough to have this bone scan, so which is specific for the heart. So it's a bone scan, but the compound used for bone scan goes to the heart in a patient with ATTR cardiomyopathy, and the diagnosis can be established.
So as we start picking up these diseases by these investigation modalities, so I would like to ask, sir, like what are the treatment available for this condition? A cardiologist, a doctor should understand what are the various modalities of treatment of these conditions. So once you pick up these conditions, what do you suggest and how should we start the treatment for these cases?
Thank you very much. So the first step is to stop the production. And how do you stop the production? Is making the ball not to dissociate into 4 components. So we use a Tafamidis, which is stabilizer. But taking this step forward, we can actually block the synthesis of transthyretin from the liver, and this can be done by using multiple modalities. Now there are a lot of advances in the genetic molecular mechanisms. For we have a small incisional RNA, so they call it as a small RNAs. Then there's antisense oligonucleotides. All compounds are in development. Some compounds are in phase 3 trial. There's a petaceran, there's interceran. All these molecules are available. In addition, what we can do is that we have certain other compounds which can help to clear the amyloid fibrils from the cells, from the cardiac tissues, and these compounds are under development. They are not that much popular, but the first step to stabilize the ball, which is a tetramer, into stable form, and to prevent the liver synthesis extra transthyretin is the way to go in the future. So the advancement of genetic therapy will be that you have to injection, which has to be not taken daily. You can take it once in a month. Some injections are more longer, and the advantage is that you are sure your patient has taken it, but obviously this comes at a cost.
Thank you, sir. Apart from this, I would like to ask something very general, sir. What we have observed is that after COVID, we see that the cases of cardiac accident, like cardiovascular incidents, have increased. Maybe due to myocarditis, which we are not sure, maybe other causes. So, do you think that these COVID type of infections or these epidemics have affected in some way the heart and the people are prone to these cardiovascular accidents?
Yes, this is a very good question. First is the consequences of COVID disease by itself. We know the COVID disease, the coronavirus, has got incidence of myocarditis, some fulminant myocarditis, some pericarditis. So this is the effect of the virus. But unfortunately, some of the vaccines which are designed for fight against the virus, they cause a tremendous immune response of the body to fight against the virus. But some of the vaccines have affected the heart also, particularly the vaccine which are the messenger RNA type of vaccine. These vaccines, when they have done, they have found out the Pfizer vaccine particularly has got a high incidence of myocarditis. High incidence means not high incidence as such as, but even when you give vaccine, because this is for protective, even one case is high enough, and this proportionally affects the younger people. So we are talking about the younger people, 20, 21, 22 years. Fortunately, most of the myocarditis are not very dangerous. People recover automatically, but some myocarditis are proven to be in a serious condition, even fatal also. And so the coronavirus vaccine, so now the people are actually, what because they are saying that our Prime Minister had a far vision when Pfizer people, they came to India and they said, we will sell you vaccine for $100 per person. And India being a population of 1 billion population, it would have really put a big setback in the economic budget of India to pay $70 billion to Pfizer and to have the risk of myocarditis because our population is also young. So it's good we went with the inactivated vaccine than to have a messenger RNA vaccine.
In the last, I would like to ask, sir has spoken about the amyloidosis. So what take-home message would sir like to give to the public and as well as the cardiologist and the physicians?
So I will give you very simple take-home messages. It's a very specialized branch, but the most important thing is first to have a clinical suspicion. Now, which patient you want to have a clinical suspicion? bilateral carpal tunnel syndrome. So if somebody has got a bilateral carpal tunnel syndrome, you should think about amyloidosis. Patient with a heart failure with preserved EF, the quantity of the heart is normal, but heart is thickened, heart has got a speckled appearance, then you should think about amyloidosis. Somebody's got some pattern of ECG. This pattern of ECG, atrial fibrillation, small voltages in the presence of a thick heart is a point in fear of amyloidosis. Somebody has got elevation of cardiac troponin and the enzyme and the angiography is normal. So somebody has got a troponin elevation, enzymes are normal, aortic stenosis. All these 6-7 conditions are, we call them in our literature as red flags for amyloidosis.
Thank you so much, sir. Sir has briefly described about this special topic in cardiology, and we would like to thank sir because sir has come all the way from UAE to attend this conference. And thank you very much for joining us. Thank you.
Thank you very much.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.